Welcome everyone to this second webinar on case-based sessions in electrophysiology. I am Kumar Narayanan. I am the chair of the APHRS Young EP subcommittee for this year. I'm from India, and it's my honor and privilege to welcome all of you to this webinar. We are going to have three speakers today who are going to be presenting some interesting cases from which we all hope to learn. And to guide us through this session, we have two very eminent chairpersons with us. I'm going to introduce the first chairperson. He's Professor Hui-Nam from Korea. He's the director of the Heart and Vascular Intervention Center at Severance Cardiovascular Hospital in Yonsei University Health System from Seoul, Korea. He is the Secretary General of the Asia Pacific Heart Rhythm Society, and he has been the previous program chair for APHRS. He also holds senior administrative positions in the Korean Heart Rhythm Society as well, and a very experienced electrophysiologist, and with special research interests in the field of atrial fibrillation and the use of simulation for antiarrhythmic drug sensitivity, as well as the issues of computer modeling in arrhythmia. So we are very privileged to have you, sir, with us, and I request you to just say a few comments about the webinar in general.
Thank you very much. Hello, everybody. Good evening. Thank you very much for your nice introduction, Dr. Narayan. And it is my great honor to chairing this privileged session for webinar. Because of COVID-19, everybody's scared, but we experienced very special, interesting webinar conference. So I hope this webinar will be very helpful to all the audiences, and we will have a good discussion today. Thank you very much.
Thank you, Professor Park. And it's my honor now to introduce our second chair. He's Professor Minglong Chen. He's Professor and Director of Electrophysiology at the First Affiliated Hospital of Nanjing Medical University in China. He's the current chair of the APHRS Membership Committee, and he's also the Vice Chairman of the Chinese Heart Rhythm Society. And again, a very senior electrophysiologist with a broad range of interests, but especially pioneering work in the field of AF ablation, as well as a lot of papers on ventricular arrhythmias. It's our honor and privilege to have you with us, sir, and I just request you to say a few words.
Good afternoon, everyone. So actually here in China is the afternoon, so I don't know, maybe there's a time difference from Korea to China, but Singapore time is the same as that in China. So this time is the afternoon, late afternoon time. So I really hope that during this COVID-19 period, everyone is going very well. And currently in China, the COVID-19 almost passed and everything is back to normal. So our cath lab is full with the cath ablations and also devices. So I also hope everyone in this period will doing well and everything will back to normal soon.
Thank you very much, Professor Chen. So now I will hand over the session to the chairpersons who will introduce the speakers, and then the speakers will go ahead with their presentations one by one, and I wish everyone has a very good session. So over to you, Professor Chen, Professor Park. The first session would be by Dr. Rajeev. So Professor Chen, probably you can go ahead and introduce Dr. Rajeev Pathak.
The first speaker, do you reschedule the schedule? So Dr. Li is not online. Dr. Li is now online. Okay, so I think Dr. Park, you can start this to introduce our first speaker.
Okay, it is my great privilege to introduce first speaker, the Professor Rajeev Pathak. He's in Australia. He's an associate professor of Clinical Academy and director of cardiac electrophysiology at the Canberra Hospital, Australia. So I just saw his slides, and he will show us very beautiful case of VT ablation. Professor Pathak, please.
Thank you very much, everyone. I want to thank APHRS and Dr. Narayan, Dr. Pang, and Dr. Chen for this kind invitation. I look forward to engaging in this webinar and looking forward to the couple of other cases. And I'll show my case. I think we'll have to share the screen here. So I'll start sharing. The only problem is going to be, how do I make it? I want to make it can everyone see my screen?
Yeah,
yes, it's visible now.
Wonderful. So thank you very much. So this is the case presentation of a ventricular tachycardia, trying to look at the EGMs, the entrainment maneuvers, and how using the 3D mapping system, we then managed to successfully get rid of this VT in this patient. So here we have a 70-year-old female with asthma and hypertension. In 2013, she presented with a palpitation and shortness of breath. She presented to emergency department, was found to have a monomorphic VT. She was going at 170 beats per minute. The usual protocol, she goes and have a cardiac catheterization and found to have non-obstructive coronary artery disease. Her EF was around 35% with mild mitral regurgitation. At that stage, a defibrillator was implanted and she was started on sotalol at 120 milligram twice a day. Few years later, she presented again in 2016 with 3 episodes of VT. These were all successfully terminated with ATP. This was all in outside hospital. At that stage, the physician who was looking after the patient decided to upgrade the from ICD to a BIV-ICD, considering low ejection fraction, and started her on amiodarone at that stage. Subsequently, in January 2017, this patient presents to outside hospital again with VT storm. She was subsequently airlifted and transferred to our hospital, where she was having multiple shocks. She was intubated, was on lignocaine infusion. Her ejection fraction at that stage, because of ventricular stunning, I guess, was even lower and was around 20%. She had moderate mitral and tricuspid regurgitation, and these were a list of her medications she was on at that time. Did an echocardiogram, of course, showing ejection fraction of around 20% with moderate mitral regurgitation, and a cardiac MRI, which was done even prior. We had these images which we looked at before we started the case, and the cardiac MR did show that she has this lateral infralateral wall, which was thin and hypokinetic. A delayed enhancement did show a scar in the lateral wall from basal to mid wall region in this patient. So this was the clinical VT which patient presented to our hospital. As we can see, patient had a right bundle branch block, a transition of around V4 region. This was inferiorly directed with a negative predominantly or S wave in lead 1, suggestive of a left ventricular VT being a right bundle branch block, transition around V4 suggesting it was exiting somewhere near the mid wall, inferiorly directed suggestive that it was around the anterior wall, and lead 1 negative means it was around the anterolateral side of the left ventricle where this was exiting from. Anyway, considering the patient continued to have ventricular tachycardia, this patient was then taken to the lab. And in lab, which is not infrequent for all of us, we see there are different variants of this VT which could be induced at different stages. I've intentionally put all of them in one slide so that the audience can get the flavor of different VTs which this patient was having. In the lab, the most predominant VT we saw was a right bundle with a really late transition, inferior axis with negative in lead 1, around similar region where the VT was, which clinical VT, which was VT2. So most of these VTs were right bundle, some of them inferiorly directed, others were superiorly directed. And there was one VT which was right bundle and what looked like an epicardial exit. And we'll come to that as the case progresses. So as we always do, these patients, when they come to the lab, if they are in sinus rhythm, we create a biventricular geometry using the CARTO sound with the CARTO 3D system, and we did create that. While we were placing the catheter, after the sound was done, this patient goes into ventricular tachycardia, and this was the VT which we saw. Again, a right bundle, late transition, and an inferiorly directed VT with negative in lead 1. Considering patient was stable, and this was well-tolerated VT, we decided to do an activation map to start with. An activation map was performed, which was plotted on the CARTO sound map, and we found the earliest spot to be around the basal lateral region, and these were the EGMs around that region. Considering the VT was stable, the decision was made to try and understand the substrate, and we looked around this region. We found there were areas with excellent mid-diastolic potential. In fact, almost continuously looking signals were seen slightly more anterior and lateral to the earliest spot. Considering again that the VT was stable, the decision was to then do an entrainment map so that we could understand and delineate the circuit. So this is the slide which shows the entrainment map of this patient. As you can see, here, the CARTO catheter, which is in yellow, represents the catheter, ablation catheter, and an entrainment map was performed. As we can see, this is a concealed entrainment with the entrainment looking, the paced QRS looks exactly similar to the VT. I'll give some of the numbers so that it helps us to understand where this region was. So here we have, the first thing we always do is to look at which one is the last accelerated beat. And as we can see here, this is the last accelerated beat. Once we understand which one is the last accelerated beat, we generally then look at pace to stim to QRS. And using the stim to QRS, we then look at EGM to QRS to decide what was the EGM which was captured. So here we see that the stim to QRS was 54 millisecond, and EGM to QRS, we found that this was the signal somewhere around here, which was captured. Using that, we then calculate the post-pacing interval minus tachycardia cycle length, and we found that we were in the circuit. So moving on, considering we were in the circuit and stim to QRS was 54 millisecond, we did stim to QRS divided by VT cycle length, which was 12%, suggestive we were around the exit area. We then moved on to try and define other areas of the circuit. We moved little anterolateral, and in this region, again, an entrainment maneuver was performed. In this region, when we did the entrainment, we found again a concealed entrainment. As you can see, the paced QRS looks exactly similar to the VT the morphology. I will again put the numbers which will help the audience to understand where this might be. Again, we look at the last entrained beat or the accelerated beat, and using that, so this is the last accelerated beat, we look at stim to QRS. Using stim to QRS of 220 millisecond, we then go to look at EGM to QRS, and we found this was the signal which was captured. We then used that to measure the PPI minus TCL, and again, we were definitely in. Now, stim to QRS of 220 out of VT cycle length of 442, which is around 50%, suggested that this was an isthmus site. Considering again the VT was stable, we went on then to do other areas and trying to define them. And we found this area where we paced it, as you could see, that there was a fusion seen. Considering there was fusion, we knew that this was an outer loop area, which was slightly lower from the isthmus area. We then go on to then also look at other areas. This was actually towards more basal region. And here we found, while we had a concealed entrainment with the with the paced QRS looking exactly similar to VT, and the PPI monasteral was in, however, the stem to QRS versus VT cycle length was 91%, suggestive that it was an inner loop. So we were really lucky, considering this VT was really stable, patient tolerated this really well. We managed to really define the circuit. We had an exit site, we had isthmus area, and we had an entrance along with the inner loop and outer loop, which could be defined in this VT. Of course, ablation lesion was performed and it terminated the VT. And then we had the opportunity to try and define the substrate of this area. So we really did a voltage map to understand the AGM and look at the signals around. We found areas which has late potential with a bipolar voltage cutoff of 0.5 to 1.5, and this was the unipolar. Using intracardiac echo and a force sensing smart touch ablation catheter, this decision was made to do catheter ablation around this area, extending from exit around the isthmus and up to the entrance area. More so primarily because there were 7 different types of VT, which was seen all almost coming from similar area. So these were a couple of examples where when the ablation lesions were performed, some of the VTs immediately terminated, while others took up to 30 seconds to a minute before we could really terminate those, suggestive that the substrate was little more deep intramural, not really endocardial only. So this was another example of the VT2, which was induced. This was the clinical VT, and we also again managed to do the entrainment maneuver, found the exit site and the entrance site based on the entrainment maneuver. And therefore, an ablation lesion was performed around the area where we discussed to almost do a scar homogenization. However, trying to limit ourselves to the areas of interest when we are doing the ablation. So these were the ablation lesion. We looked at the unipolar and bipolar map, and ablation lesions extending from the basal inferior area to slightly anterolateral area. An ablation lesion was performed in this region. Now, while we were pace mapping, just to understand those areas and see areas of non-capture, we saw this signal where with the pace map, we could almost see the signal exiting towards the epicardium, as you can see this long deflection index, and then inducing the VT6. As we saw this, the decision was then made to go epicardial to be able to map in the epicardium to understand if that is part of the circuit. As we see here in this map, this is the bipolar map of the epicardium. Essentially, we saw a normal bipolar voltage. The unipolar also did not show significant changes except for the areas of interest in the endocardium. There were some areas which we could see the abnormality. Now, we did change the upper threshold from 1.5 to 2.5, and interestingly, we saw this area which did look like there were some bipolar abnormalities which could be seen. So we then went into that area and looked endocardial and epicardial directly opposite in that area. In the similar area in the endocardium, we could find these sharp signals. When we looked in the epicardial, these signals were really far-field looking. Entrainment was then performed in this region to see what we could find. And realistically, this area looked, there was a obvious fusion which could be seen, and entrainment confirmed that this was out. However, patient was in VT, and considering this was directly opposite to the endocardial area where we did targeted ablation, a decision was made to ablate so that we could sandwich that area. And to our surprise as well, ablation in this region led to termination of VT very quickly. And therefore, we decided to sandwich this area from the epicardium and endocardium to try and get rid of the substrate, which may be made myocardial as we suspected initially. After 9 hours, we had a non-inducible VT. The VT7 still could be induced. However, that was only with 400 triples, and that was non-sustained. Patient, as we always do, stay in hospital for 48 hours, and we then take these patients back to the lab to do a non-invasive program stimulation to see if we can induce any further VT, and there was no inducible VT seen after 48 hours. So realistically, we have few points we can discuss in this: the role of entrainment mapping, how to identify epicardial and mid-myocardial scar, role of voltage mapping, and to try and have a shifting bar of the upper cutoff so that we can try and identify the substrate in these regions, and rather than having a fixed sliding square. I'll stop at this stage, so thank you very much for the attention.
Thank you very much, Professor Panta. It's a beautiful case, and I think that most of the electron can be published in the textbook. It's a textbook like a clear electrons. There's no doubt about the electron analysis and the mapping techniques, but I would like to ask several questions about the practical issues. This Absolutely. Is very, very sick patient and intubated, and the VT, recurrent VT, ICD shock. And when you decide to do procedure, which factor do you consider first? And after this long procedure, which factor you have to be very careful?
So planning of these procedures are extremely important. Pre-procedural planning to understand if this patient is going to be able to tolerate a long procedure. The Penn group, where I got my fellowship done, we have Dr. Santangeli has published this pain score, which helps us to ascertain how are these patients going to be able to tolerate this hemodynamically, or they need some hemodynamic support. Now, in this particular patient, it was surprising how this patient tolerated this VT so well. Of course, using either inotrope to try and support them if need be, or doing limited entrainment map and not to keep them in VT are some of the factors. So I would suggest if the patient tolerates the ventricular tachycardia, it's good to be able to at least do a limited entrainment map so that we can define the circuit, and then look at the substrate and do a substrate-based ablation after that. Now, if these patients do not tolerate VT, in those patients, of course, we'll have to just define the substrate and do scar homogenization to be able to try and get rid of. Now, the factors which I use to assess if these patients are going to tolerate will be, of course, ejection fraction, if they have comorbidities like kidney and renal impairment, or they have lung problems, the capillary wedge pressure, how much fluid overloaded these patients are. Invariably, I will put a swan to understand the capillary wedge pressure in these patients. And based on those, we make a decision. And I have a cardiac anesthetist who works with me in the lab, which makes my life easier because there is someone who is trained and happy to be able to give me hemodynamic support if need be. But in the centers where they don't have an anesthetist or a cardiac anesthetist to support, I guess pre-procedural planning remains extremely important. Now, this is pre-procedural. During the procedure, again, it becomes important. While you're going through the case, you need to have a team of people who will be able to continue to look at the hemodynamics, measure the lactate and a pH of the patient as the case progresses to see whether the patient is actually tolerating this long procedure or not. And have to have almost a confidence in the team. If your anesthetist says, look, we'll have to stop this at this stage, that you'll have to take that decision. We use Impella if need be, if there is a low ejection fraction and these patients really need to go on. We have used Impella in few cases, which is a percutaneous LVAD device. Or in some patients, if we think it's a high risk, these patients then go on ECMO before we get their ablation done. So that will be intra-procedural planning. Post-procedure, my patients always, if they are sick, go to intensive care. And these patients will be monitored at least for 24 hours with hemodynamic support if needed, before we then slowly wean down those things in the next day.
So in which case do you back up the ECMO or Impala during VT ablation procedures? All the cases or in some specific indication?
So for us, like I said, using the pain scoring to see if these patients are at higher risk. If they have renal impairment, comorbidities, low ejection fraction, which is less than 15% or so, in those patients, if they do not tolerate hemodynamically, this patient came in VT storm, was tolerating VT anyway. So we had idea that this patient tolerates it, but you have a patient who does not tolerate VT and requires to be shocked immediately to come out of VT to maintain hemodynamic support. You know that those patients who will need a hemodynamic support to start with before even you start a procedure.
Okay, thank you. Excellent. There's another written question from Dr. Yamin. And what was the reason to ablate the epi-VT at the same sitting, considering the long procedure time, risk of complication? So in which point do you enter the epicardial space?
So as I told you that we were doing pace map and looking for areas we need to burn endocardially. And as we paced, we found an epicardial exit and patient went into clinical VT. So we are in a situation where the patient still having inducible, stable clinical VT, and we haven't got rid of it. I've done an extensive substrate modification in that region. Targeted areas of isthmus and early entrance and exit sites, I'm still having VT. So clearly there is a mid-myocardial substrate in this particular patient, or there is a possibility that there is an epicardial substrate in a non-ischemic patient. We all know non-ischemics do have mid-myocardial and epicardial scar. And this is a non-ischemic patient. There was no obstructive coronary artery disease. So in these cases, when you have non-ischemic patient, when you have a VT which is still inducible, and you have evidence that you captured epicardial and then went into VT, I think at that stage, we decided if we are to try and eliminate this, we will have to go epicardial and map it. And that's why we did that.
So there is another question from the Dr. Kolandai Sami. And was there any evidence of ECG findings suggesting epicardial location?
So if we look at the series of ECGs which we had here, realistically speaking, initially there was none of the ECG changes which suggested that there was a epicardial exit. Most certainly the VT1, VT2, we did not think had, epicardial exit. But if you look at VT7, we did have a long MDI. However, saying in a non-ischemic patients, not infrequently in this region, will have mid-myocardial and epicardial substrate.
So many people has the interest in the epicardial access. Another question from Krishna, Dr. Krishna, and the question was the heparin reverse before the taking epicardial. How do you use heparin reverse or not before epicardial puncture during the procedure?
So of course, when you're doing endocardial ablation, you will keep your ACT above 250. And before going epicardial, we do give protamine to get the ACT low before we get an epicardial access. Most certainly, when you're starting, you should definitely do. But in my standard practice, I still give protamine to reverse the ACT before I do so. Okay,
thank you. There are so many questions coming up, but because of time limitation, I would like to ask the last question by the audience. During entrainment mapping and PPA assessment, how do you differentiate local V from far field?
So that's why what we will like in these cases to do is to look at the stim to QRS. If you look at, there are two different ways you can do. You can do stim to QRS and look at to start with, you look at which one is the last entrained beat. So this is the last accelerated beat in this particular case. Once you know which one is the last accelerated beat, then you look at stim to QRS to that beat. Move that from stim to QRS to EGM to QRS, and that's how you'll be able to decide this was the EGM which was captured. And that's where you measure it. Is that the question which he wanted to find out which EGM was captured?
His question was how to differentiate from local and far field. Well,
Local versus far field. I mean, the local signals are more fractionated, more high frequency signals, whereas the far field signals are like this slide here. Now, this is the local signal versus this is more far field looking, low fraction, far field looking signal.
Yeah. So fractionation and the sharpness of signal
Sharpness.
Yes, to differentiate the far
Sorry, there was a dropout in the sound. That's why I could not understand the question before.
Yeah, the other questions are coming up, but I would like to emphasize the epicardial, the mapping and ablation. You do not have to hesitate to enter the pericardial space in case of non-ischemic VT cases because it has been reported over 40% of non-ischemic VT coming from the epicardial side, and even though we are using the contact force and the high power ablation, the endocardially ablated, the epicardial focal is not successful. So sometimes we just map the epicardium, and ablate from the endocardium, but the epicardial mapping is very helpful for the non-ischemic VT. Another point, if the patient has potentially sarcoidosis or other inflammatory infiltrative disease, those patients have progressed disease. So even after successful VT ablation, the patient can progressive heart failure or recurrent VT. So you need to discuss about that before your procedure with family and the patient.
Absolutely.
Okay, Minglong, yeah. Professor Minglong Chen, do you have any other comments? Brief comments?
Silence. Okay, so that's really a wonderful case, very beautiful ECG tracings. So this is really a teaching case showing how to do entrainment map. So one question to me is that before the patient was discharged, you often do the non-invasive stimulation using ICD to see whether VT is recalled or VT is completely controlled by catheter ablation. So that's regular practice. So if, for example, the patient, the VT can still be induced, how to do next?
You beat your luck. So I think that
yes, I think this is a very tough question, but you do the stimulation before the patient was discharged.
Yes. So look.
So how often do you? Most of the patient, if maybe 70% or 80% before discharge, you do the non-invasive stimulation. The VT is, there's no induction of VT. That's good, but for those, who are still the VT can be induced, how to do next? So it's a tough question, I know.
So Dr. Chen, that's a really practically important, especially for our lab where we always do non-invasive program stimulation before sending.
Mm-hmm.
So we know the patient's clinical VTs because we have spent time, we have documented those. So if say next day or after, not next day, 48 hours later before discharge, if by putting singles or doubles, I'm managing to induce the VT again,
mm-hmm.
in those rare circumstances, I must say in last 3 years, I'm back after from US, I've had only 2 patients where we had to take the patient back into the lab again.
Uh-huh.
Most cases, you induce with triples. So say 400 triples, if induces a VT, which we never saw, I will not take that patient back to the lab. However, if 600 single, and I end up inducing the VT again, unfortunately, you send the patient back home, you're talking about within next few days, a VT storm and patient comes back again. You rather take them back into the lab, see what you have missed, if there is anything, speak with your colleagues and see if there is anything else which could be done in this case to try and help that patient, I guess. Huh?
Okay, good, thank you.
Thank you very much.
Thank you. Okay, Minglong, why don't we move to the next case?
Okay, sure. So
I'll stop sharing the
Professor
screen.
Benta.
Thank you.
Okay, let's move on to next case. So the next case is presented by Dr. Li from Hainan University, Medical University Hospital. So Dr. Li is the senior electrophysiologist in Hainan Medical University Hospital. So he's going to present atrial flutter case. So that's welcome, Dr. Li, please.
Hi, hi, Professor Chen. It's time to share my screen. Can I start right now? Okay.
Okay, start. Please start.
Okay, I try to. And that's so. Okay, can you see my slider? I will. Now, okay. Can everybody see my slider here?
No. We cannot see.
Still no. Oh. There must be something problem. I come back to adjust it. Yes. Oh no. Yes, you can. Now I saw my slider again.
Okay, it's coming.
Can you see me? My slider?
Okay, it's good. It's good.
Okay. Okay, let me start it off. Honorable Professor Pathak and Chen, Jenny, and you do. Please allow me to show my pleasure for APHRS. So give me such an opportunity to share my experience and my communicating with the top EP expert in Asia. And today I'd like to present the case about a refractory atrial flutter after the May 4th surgery ablation. First, I will introduce the patient's briefly. So the patient is 70 years old male, has been completed recurrent palpitation for 3 weeks. His ECG is in Yahweh spread as the persistent atrial flutters. And he was placed a guy with recorded dosage of amiodarone and metoprolol following the hospital is discharged, but still cannot stop the upset. And his precious cardiohistory is in 2040, the patient was diagnosed as rheumatic heart disease with mitral stenosis and tricuspid regurgitation and proximus artery fibrillation. And then he received as the mitral valve replacement and tricuspid void or plastic. And first, the Cox-Max4 procedure was performed on him. After 2 years, and the patient present with the recurrent palpitation and referred for break. EP study illustrated as the mitral isthmus dependence atrial flutter. And his ablation here terminated the expositor, but no bidirection block, and this displays after repeating ablation for many times. And this time he come to our hospital. We checked this ultrasound. The results shows that artificial valve functions normally with slider with the tricuspid valve regurgitation and aortic and distal regurgitation. And this time we showcase the ECG. He gave me as two one fractures conduction with fracture morphology negative in E1, and the front wave's amplitude was attenuated. It's not clear. So even saying okay, no visible F wave here in the E1, and no visible band P inverted P wave in the ABL at 2 and 7 at the ABF gate. All of this and from ECG we can to guess is atypical atrial flutters. Oh, that's the issue. That's the EGN. We tested the Howard test the TCL. It was 270 microcelsius seconds. So we can show that coronal cell signal that indicates there's the proximal to distal activation, and there are lots of this far field components here as CS 9 to 10, and his the fractionation portion. And between the CS9 to 10, as you can see here, there's many fractionate potential here. And we show we can see that there's the relative map. Because we know that this position of the CS9 to 10 here, we show with the mouse track here, it's more close to regular CS7 to 8 position. So it suggested that the potential will more probably come from this block room across line from the isthmus of the artificial mitral valve, this place. And another one place we come to the roof. The left panel shows the bivalve relative map. This indicated the region of the scar of the tissue present with the noted called it here. The roof. That's we saw in the yellow line. There's the conduction in the LAT map. Moreover, there's more voltage from scatter. They scatter in this place. Just gap between the health tissue purpose between cells correlate with the no entries but LATPs. We guess because they are very scattered with it is the mapping here. There will be no rarely re-entrance circuit here. And the right part is with the local activation time as the earliest point. And it shows the red color, that is the red color, shows the power cut here. And the roof of the atrial. It's complete, its conduction block. And we can see the blue at the roof. That's the point. And showing both late and local and double potential. Double potential here shows that these earliest active points are close to the pattern of mitral isomersis. The scar, that's the scar. Okay. Okay, we next move to the post-real world. I can see the many DP here. The left panel shows the bipacular wave indicates the region of the scar. This yellow shows that yellow lines. This correlates the post-real world areas of the conduction block in the LT maps. In the LT maps, the right panel, we can see that's the another one, another yellow that is here, and we can see there has the another one. Yellow line shows the block one, but we still have see there's some DP here, and that's the block reduction. That means that we re-entry can maybe come from here. And we use the active mapping again, where we show that in the roof of the post-war, both indicate that the earliest area where early gate is very close to mitral isthmus. And the entrainment from this site will reveal it's part of the re-entry circuit. Active map shows the re-entry path. There's the Y line and arrow. The propaganda wall front is passed from the MV, pass around MV in the counter-cross direction, counter-attack direction. So we guess that's the two line lines that shows that maybe there comes the block here. We just need to operation across very close to the MV, and those is the show us that indicate all the proofs that says the point to the micro atrial and the atrial fractures. Oh, okay. The next problem we made is possible, and the dual roof by atrial microatrial path fracture, from the right, the artery, and drive the left artery. Another activation multi-mode mapping from the area and I show that no voltage run of the engaged conduction. Engaged conduction here, perhaps the required to establish whereas is whether the range only exists only around MV. So we tested, okay. We run the test by Chen can show me clear that this is the typical FLC. It's just only buried. There's no only buried. There's no mitral re-entry. It comes from the, can establish the buried mitral re-entry. Okay. What we next decide what we do, what we have done several next. What can we say with the patient has received the cox specs for the procedure? So what can do? Firstly, they hit the right side primary wire isolation. From the left panel, we can see it. And they will operation for the IVC, SVC, and the right artery free wall. by C2 here, and we use the biparallel clamp to come to a pitch ablation. And when it comes to the Casper animals, they come to use the ablation here, so the working. And when we close behind us and the left pulmonary rounds, we use the ablation again. That's the red color. That's the red color line shows that we come to the ablation line here. So we have discussed there the three agent lines or comes corrected by the surgery. The first one is to get the one smooth line here and the isthmus line here. Another one he comes to with as the connection line between IVC and SVC. It also shows it right pattern on. Okay. The second challenge of this case is how to decide the ablation line here. We have two choices. The left one we use again with the isthmus set and move to the LIPV, and the right one that we use the start with the button of the mitral virus and to the RIPV. What we decided? Okay, that's the first choice, and that's the second choice. Why we do this? We will do this decision because the patient has received operation. If the patient did not receive the operation, we prefer to choose the second strategy, the second place here. But the pair areas of the very low voltage around the mitral isthmus indicated the scarred tissue recreated by the surgeon will be the barrier of the completing the ablation lines. So we think this maybe this is the one of the reason we failed to continue his keep his normal horizon. So we choose another line. This we according to this one or to the first one. This the line from this bottom RVT from here to here. There's the IPV. Okay, I have to make some presentation here. This my photo taken by my iPhone. It's not so clear but when we take this photograph, we use the cattle-free system, and by 3 years ago, and this time we change another version, the inside system. So when we come back to the old system, if I have all the data lost, only take some photo here. It's not so it's not so clearly, and we see separation here. At the side we use the quantity separation here. The request line. When come close, only 40 seconds. Only 40 seconds. This is terminate. But the picture is so next. So DV comes close, slower, and keys comes to ablation at a very short time. It's enabled to induce by stimulation and by direction block is achieved. So such many very slow time to complete ablation means we must do something right. But is the end of story? No. It's not end of whole stories. It's not so easy for this case. We still missing some problems. The patient, after 1 month, he kind of discharged. The patient has recurrent arrhythmia palpitation. He come to us as hospital. Come to our hospital. Just only remained Flutter free for 1 month. We have made the EP study and show the TCL is prolonged than before, and we'll have SO4 with 270 microseconds. So it has prolonged 70%. And the interval of the PPI, the minus TVCL and the HRA, and during the pace both less than the 50 microseconds indicate the AFL probably original from the right artery. Right artery? Oh, so it comes to right artery. Whereas before the patient has received the tricuspid valvular surgeries, it has rebuild the right artery substrate. So some may troublesome makes for us to use this catheter. The APHRS different point in the Aristotle. The earliest areas where early means spread from the 7 to 8 clock direction, and for the counterclockwise. Okay, that's the photo. This TV. I feel the counterclockwise reentry tachycardia circuit around the TV. After 9 years operation of this can cause this part. This we can see the red parts. We can fall operation eye here. So we get it. The TCL program is no longer. It comes to 360 megabits after the operation. That's what it means. So we come to the right again, and he's come to map. We find these words. Okay, that's that. We set the blue color with the IVC and SVC connection line, and we find this the red and the purple border. There's a gap here. There's a gap here. That's the without the change of the CS activation sequence. So is a clear gap here. So we comes to DMS, maybe that indicate the incomplete block of the procedure. So we come back to our procedure. That means the right hypothesis of the mechanism. We know when they close the left artery appendage, they will stay using here and showing in the red diagram. The position of the gap remains as the close of two layer running by C2N and stage of the LA from this surface of the LA. Probably is create a local problem here. The tissue will become scar, will be something will become obstacle of the touch of the next cerebration clamp. It reports accomplish the transmutation. So we take the linear abrasion across this line. We can see it's not complete following this line. At the upper one, we have the very short the segment here, and with all the run of the gap, we still have the abrasion. That's the deep gap. So the abrasion line complete. So how about this reason? Okay, it's suspend the word first times again, and she says that it cannot be inducible, and the patient since remain techno-free on the ADS for 1 year past schedule. So that's my case.
Okay, thank you, Dr. Very good case, but very complex. Also, the substrate is complex. So I think, can you show us some of the entrainment pacing in the left atrium in your initial ablation procedure? Dr. Li?
I'm sorry, Chen, I can't catch you what you say. It's very crowded. I can see clearly. Can you repeat?
So can you show us the entrainment pacing in the left atrium in your initial ablation procedure? Can you hear me?
I still can't get it. Can you repeat again?
So we want to know the entrainment pacing in the left atrium in your initial ablation procedure.
Ablation procedure. I just hear this one word. I cannot get other words.
So the okay, can you hear me?
Can you type your answer? I think my connection is not so stable here.
Okay.
Okay, Minglong, because of the connection issue,
Yeah.
I would like to talk
Yeah,
about
I'm typing.
Left atrial entrainment. Okay, I come back to my slide. I'm sorry, Professor Chen. I may not have the entrainment map here. I missed one slide here, so cannot show he for us. That's one problem at MIT.
So
I said
actually, the initial flutter case in the left atrium is the atrial flutter going around mitral annulus, right?
right.
And why do you choose the line in the inferior floor from the mitral annulus to the right inferior, but not choose the line between mitral annulus to the left inferior? Because the previous cryoablation line created by the surgeons is there. So if you do the initial line there, I think that would be quicker and shorter. Can you hear me?
Okay. Okay.
So
That's a
why
very
because this is a mitral isthmus dependent atrial flutter. So why do you choose the line? But that's quite a longer line from the mitral annulus to the right inferior, but not the line from the mitral annulus to the right to the left inferior, because that's the initial line created by the surgeons.
okay. When I come to choose the ablation lines, we first want to, there's the ablation line here. Okay, is this the slide? Okay, no, this is the slide. Yes, this is the slide. We will consider about this, the problem. The patient has get the coxswain surgery, especially because before the catheter, he can get this mitral valve replacement. So there must be many scarred and the tissue here. So we cannot attach or make the perfect attachment. So we choose another one to run the first test. And so fortunately, it sustained, it terminated the FAL. So we finished the whole procedure here.
Okay.
That's my maybe one I cannot consider very clearly. Thanks for your guide, and it's just very helpful for me.
Okay, you mean that the typical mitral annulus region, so you cannot have a good contact, right?
Yeah, yes, that's why.
Okay, so do you use contact force catheter, or I think you are using the contact force catheter?
Sorry, Professor Chen, I can't get you.
So I think you are using the contact force sensing catheter. So you can know the contact of the your catheter to the local tissue in the mitral region.
Oh, in this case, we have chose because the energy organ case is here. We want to try to ablation is the first choice. After we change to another type of the AVL, we found this is very difficult to get it. So we come to remap the right artery. Do you understand me? I get carefully fast. It's really not so clear here.
Yeah, the connection is not so good. Okay, so I have a question. The other question is going to the right atrial flutter. So, do you think it's reasonable in such a case that you do the TV cable tricuspid isthmus ablation line in your initial procedure, because the substrate is so complex, it's easier to develop the right atrial flutter after that. So do you think it's reasonable to do this TV annulus line at the same time in the initial procedure?
Okay, I showed this first time I used the ablation here. And the slide showed his complete ablation. Okay, I can see here. That's the termination of the atrial flutter. We use the contact force here. We can show this the 13
gram,
and the angular of this touch contact force is at the show is separation here, and this contact force is consider is the best choice for us. But sometimes we consider that we have to some problems in uses because the patient cannot afford most of this is the price. So
okay.
this is what we do. I'm sorry about it. He cannot get your answer.
Okay, when I hire you, do you have any comments?
Let me give several comments and would like to share my experience for the post-major AT ablations. First of all, I would like to strongly recommend to review the OP record before the procedure, because every surgeon tried to modify their own method. As you saw in this case, the previous surgical maze, the surgeon did not make a posterior box isolation, and he did not make a cable tricuspid isthmus ablation. But in the standard, the Cox maze 4, it should be posterior wall should be isolated, and the cable tricuspid isthmus should be blocked. So because at the depending on the operating condition, the surgeons change their strategy quite often. So you need to read the operation record very carefully before the procedure. Second one is, if there is a mitral ring or tricuspid annular ring, it's very difficult to make a complete block because energy penetration is limited. And also if your catheter tip touching on the mechanical valve, the impedance change, and usually the RF delivery just automatically stopped. And the third one is, even there is a complete, looks like complete, the perimitral block, I saw many cases of still there is a perimitral reentry because of epicardial conduction. So even though endocardially there is no potential around the perimitral area, still there is a perimitral reentry through the epicardial conduction. So sometimes it is very, very difficult to block the perimitral reentry. So sometimes I use anterior line instead of a left lateral isthmus line. Is difficult to block. And the last one is, if you try to make a cable line in the right atrium, you have to be very careful to avoid the sinus node dysfunction. Most of these patients has underlying sinus node dysfunction because of a long-standing persistent AFib and the significant right atrial and left atrial remodeling. So if you're a little bit away from the cable line the surgeon did, you have a high chance of a sinus node dysfunction, and patient needs the pacemaker. Okay, it was a very nice case, Dr. Li. I enjoyed your case presentation.
Okay, I quite agree with you, Hui-Nam. Because for us EP doctors, we not only should do the current, the tachycardia, but we also should do something to prevent the future tachycardias. So in this case, in this particular case, we would like to do, because on the left side, you already have terminated the mitral flutter, but on the right side, or even the left atrium, you should do the sinus map to see the substrate. So on the right side, if you do the substrate map, you can see that the lateral line was not directly connected to the IVC and SVC. So in the initial procedure, you should join this line to SVC and to IVC to prevent future macro reentries. And also you should do the cable tricuspid isthmus line in the initial procedure, because I think after maze 4 procedure, maybe 15% of the patients, if you don't do cable tricuspid isthmus ablation, they will also develop the right side atrial flutter. So in the initial procedures, we should, after we terminate the culprit tachycardia, we should also do some substrate modification to prevent future macro reentries. Okay, since time is limited, let's move on to the next case, Hainan.
Okay, thank you very much, Minglong. It is my great pleasure to introduce this last case. Let's proceed a little quicker. I do not make your wife and children angry on Saturday afternoon, Saturday evening time. The third speaker is Dr. Dony Yugo Hermanto from Indonesia. He's a staff of Arrhythmia Division and University of Indonesia National Cardiovascular Center, Harapan Kita, Jakarta. Currently, he is working in the EP fellowship at the Vetricular General Hospital in Taipei, Taiwan. Dr. Hermanto, please.
Okay, good afternoon to all the attendings and the presenters. So thank you for the opportunities. As I mentioned, I'm Indonesian, but now currently doing EP fellowship in VGH. So now I want to present a case we encountered in VGH like 3 months ago. This is a SVT case. So here's a 25-year-old male with complaint of palpitation, and history is syncope is denied, and has 2 failed SVT ablation before. And through echo, he was diagnosed as having a Ebstein anomaly and frequent SVT episodes. And the echo is here, and it shows a classical sign of Ebstein anomaly that's apically displaced tricuspid annulus at the septal region. And this was his baseline ECG. It showed a short PR with delta wave to the RS transition in the precordial leads, which is around V2, V3, and the axis is a superior, so might be suggestive of a right posterior location of the accessory pathway. This is the RA graphy, angiography of the right atrium at this patient. You can show here that the RA is quite big. There's the atrialized portion as well of the RV, and we can see here at the right side, the CS ostium is quite big. So we did the catheter placement on this patient. It's quite standard, HRA, his, and etc., etc. So this is the baseline interval in this patient. It's quite normal values, all the baseline intervals. And it's just the retrograde conduction. This is the VA conduction in this patient. And we can see this is the eccentric activation pattern of the atrial. And this extra stimulus spacing showed non-decremental properties of the retrograde conduction. So non-decremental, so suggestive of more of an AP conduction retrogradely. And then after the retrograde ERP was achieved, it's always followed by the 3 beats of echoes. We can see here, this is the echo beats. This goes to here and it's echo, but it's not sustained. It's only echo beats, but it's quite persistent. The echo beat is always there after we reach the ERP of the AP. But the echo beats here, we can see the activation pattern is quite different from the V pacing. It's quite concentric at this tracing. So this is the retrograde AV and ERP. So after AP, ERP, AV and ERP, and then this is the AV and ERP at around 370. And this is the antegrade conduction. And the antegrade AP study showed non-decremental properties of the AV interval with progressive pre-excitation throughout the pacing period. And then after the APHRS reach the accessory pathway reach the ERP, it always followed by the SVT, just like the retrograde before. But now the SVT is quite different. If we can see here, the atrial activation now is changing again. It's more likely the same with the ventricular pacing atrial activation pattern. But the SVT, we can call it this SVT1, it's non-sustained. So it's very difficult for us to do the maneuver on this situation. And this is the ECG of the SVT1. So we can see this is RBBB morphology. And this is, if we compare the retrograde activation of the SVT1 here and the ventricular pacing, it's quite the same atrial activation pattern. And then the SVT is terminated spontaneously. And we can see here, luckily, there's a VPC that terminates the SVT, and it's fall. The PVCs fall in the His refractory period zone of the His. So then the A signal here after the VPC, it's not passed through the A, so we can suspect this is more likely of an AVRT, because this quite pathognomonic maneuver or pathognomonic termination. But so because we cannot do the maneuver, so we did the isoproterenal infusion, and during isoproterenal infusion we can induce SVT. But instead of the non-sustained SVT pattern that we had the different one again. It's the atrial activation pattern here is different. It's more of concentric, the atrial activation pattern. And it's quite the same with the 3 echo beats that we encountered earlier. So we can call this one is SVT2. So this is the difference of the ECG between the SVT2 and SVT1. We can see here it's quite similar actually, but in SVT1 is a little bit broader, the QRS, and we can see in the inferior leads it's quite different. So we have two SVT. So what do we have so far here? As a summarize, this SVT1, this is this TCL of the SVT1. It induced without isoproterenal. It was non-sustained and eccentric activation pattern, similar with the V pacing. And then the VPC at his refractory stopped the tachy without the A proceeding to or going on to the atrium. And then we have also SVT2 with the TCL of 322 induced after isoproterenal, but have concentric atrial activation pattern. So what we did is first we did the AV ablation first, because it's the clearest one. So we did the AV ablation first, and then we mapped around the tricuspid annulus, and we found the earliest A during V pacing at 12 o'clock region of the tricuspid annulus. So we did multiple ablation at that area, and the activation pattern we ablate at during the V pacing. So we see the earliest A, and during the V pacing as well, we can see the activation pattern goes concentric at this site. So this is the successful ablation site. It become concentric. And then we did another the 12-lead ECG, and it showed the loss of delta waves. Now the ECG now showed RBBB, a complete RBBB, compared to before this delta waves here and there. And this is the fluoroscopy of the ablation site at the 12 o'clock of the tricuspid annulus, because it's quite big. So this is the place. And then we test another for the VA conduction, whether it's the VA is still using the AP or the AV node. It's suggestive more on AV node, because the first is the concentric pattern of the AP, and then there's a decremental conduction as well. But we could not also exclude the possibilities of decrementally conducted AP as well. So We did another inducibility test, and not surprisingly, we can induce another SVT. And the SVT now, although the ECG is quite different from before, but the atrial activation pattern is quite the same with the SVT2 that we encountered earlier. It's concentric pattern. So we did the VOP maneuver, and the VOP maneuver showed the VAV pattern with the PPI minus TCL of more than 115 milliseconds. So it's quite suggestive of SVT due to AVNRT. And then luckily also we can do his refractory pacing, because it's quite difficult to get his signal because the tricuspid regurgitation is severe in this patient. So his refractory pacing already confirmed the presence of the no reset response at this tracing. So you can see here it's quite valid, 25 to 55, and there's no reset. Actually, it's a little bit advanced, but it's less than 10. So it's considered no advancement or no reset during this procedure. So we have the SVT2 that have VAV response with long PPI minus TCL and no reset in the his refractory, and also we get decremental retrograde activation. So it was suggested or likely to be an AVNRT. So what we did is we proceed to the slow pathway ablation. This is the slow pathway ablation, slow pathway mapping we did, and we can see the good ratio of AV interval at the low coach area, and we did slow pathway ablation around this area. Accelerated junctional beats was observed, and then the VA dissociation is shown after the ablation of the slow pathway. So there's a VA dissociation after slow pathway ablation. There's no VA conduction anymore. But during the inducibility test, we induced another SVT. Okay, during isoproterenol, we can induce another one, but the atrial activation, once again, it's different from the before. Okay, we can see now the atrial activation pattern. The earliest it's in the CS around 9, 10, 7, 8, and it's very different from the two previous SVT. So we suspect this is more likely of an AT, because we already ablate the accessory pathway and we already ablate the slow pathway, and we have a retrograde block. Retrograde conduction is no more, so it's more likely of an AT. We think of that. So we did this is the ECG, by the way. It's RBB as well. And then we did activation mapping on this SVT, and we found the earliest activated sites is near the CS ostium. It's around 40 milliseconds before the CS signal. And then we did the ablation during SVT, and our ablation could terminate the tachycardia without any APC. So this is the location of the ablation of AT. Is in the CS ostium, near the CS ostium. This is the 3D ablation lesion that represents all the three ablation that we did. This is the ablation for the accessory pathway. This one is for the slow pathway ablation, and this one is for the AT ablation. I'm sorry, I could not show the LAT mapping because of the program issue. Okay, so this is the resume of this patient. He has a Ebstein anomaly and manifest WPW with posterior accessory pathway. He had a orthodromic AVRT as well, using posterior accessory pathway, and a typical fast low AVNRT, and as well as the atrial tachycardia that originates from the coronary ostium. Okay, so this is the final ECG on this patient, and gladly this patient come again to the hospital and showed no pre-excitation or tachycardia whatsoever. And after that, he went for con procedure, the surgery for the Ebstein anomaly, and showed good results, and no more SVTs recorded during that time. Okay, so I conclude this presentation. Thank you.
Thank you very much, Dr. Hermanto, for your excellent presentation, and congratulations, your successful procedure for this complicated case. So actually you ablated 3 different tachycardias in a patient, am I right?
Yes, 3 in 1 patient.
Okay.
It's quite a long procedure.
Always the Ebstein anomaly has a lot of
Yeah.
And
We thought it will be only an accessory pathway, but no.
Right. Sometimes they have their multiple accessory pathways.
Yeah.
So do not make a dinner appointment when you have the Ebstein case.
Yes, absolutely. Luckily, we did it in early morning.
There are a few questions coming up to the message. And first one is from Dr. Chen. How do you define the tricuspid annulus position during ablation? It is a very, very important question in case of Ebstein anomaly.
Yes, it's a very important question, and it's quite difficult to answer. So this is the specimen of cardiac anatomy in Ebstein anomaly. So there was a atrialized portion of RV that become the atrium. So what we define as a true AV groove, or the annulus, is actually the place that the RCA is there. So the place where the RCA is lies. So this is the true AV groove in patient with the Ebstein anomaly. And then the other thing that we can define of the AV groove, of course, the presence of the A signal and V signal in EGM. But to define the true AV groove, we can still rely on the fluoroscopy, and we can do coronary angiography as well to see whether where's the location of the RCA and the AV groove as well. Maybe you can have another additional opinion on that.
So when you ablate the case of Ebstein anomaly, defining the true AV annulus and the functional atrialized ventricle is very important. So traditionally, our teachers recommend to do right coronary angiogram and at the fixed fluoroscopy angle, and show it on the screen, and comparing your catheter position and RCA. Usually, even though the RCA, the location does not match perfectly with AV groove, but you can estimate where is the true AV groove. And this patient also has a very huge right atrium, mostly atrialized ventricle, but you need to define where is the tricuspid valve level. So generally, the accessory pathway location is in between the true AV annulus and the tricuspid valve location. So, and sometimes it's very difficult to manipulate the catheter because of its big atrium and big. Sometimes the long shear support is very useful to map the clear mapping of your accessory pathway position. But you use the 3D mapping system, right?
Yes, we use the 3D mapping system as well to use for the
3D mapping system is very, very useful to map a clear map of Ebstein anomaly. And there is another question. CK, Dr. Ching in Singapore, he asked a question about what is the STEAM A and VA interval for SVT number 2. And there's another question from Dr. Kumar. How did you map the slow pathway in Ebstein? Annulus landmark are not in position.
Okay, so the VA, I don't think I have
so VA interval during pacing? or SVT number 2?
SVT number 2. This is SVT number 2. Okay. The VA, but I don't have the slide for the VA interval pacing and the VA interval during pacing, and I only have this, but I don't have the V pacing for this tachycardia cycle, and I don't have that slide. But the VA pacing during the VA pacing showed concentric activation.
Okay.
But I don't have the measurement. Maybe
I'm
I
not
just
sure
don't.
the answer enough for the CK's question. And the next question was, how to map the slow pathway in Ebstein?
Okay, when we did mapping the slow pathway in Ebstein, actually, if we rely on the AV diffusion, it's quite difficult because we're not sure whether this is the A or the V, because we are not sure as well about the place of the tricuspid annulus. What we can do is we did the angiography first of the RCA, and then we map. And the V pacing is also useful during mapping for the astral pathway, and we can see the earliest A. And then the other thing that you can do is you pace from the V, but in different sites. So especially in differentiating between slanted astral pathway, so on and so forth, maybe differential pacing from different sites could be useful for identifying the slanted pathway or so forth.
Can you show us the slow pathway potential of the ablation signal when you just before you ablate the slow pathway for the AV node reentry?
Okay.
And the Dr. Mazumdar also the mention about the epicardial fat pad position also shows the annular position location. Yes, that's right.
Yeah,
usually
this
runs with the epicardial fat. Okay.
Yeah, this is the potential, but I don't have the slides for the non-pacing. This is for during the V pacing.
If we can see the sinus rhythm, the ablation potential, that might be better.
Yeah. I'm sorry, I don't have that one.
And Dr. Fabian asked to Dr. Hermanto, do you use 3D for the beginning at the beginning of the procedure, or you switch to 3D mapping during the procedure?
Oh, because we know that the Ebstein case usually have a very tough case, so we do the 3D ablation from start, the 3D system from start, so we can delineate where's his potential, and then during the V pacing as well, we can see where the earliest A we can use it, the earliest A using 3D. So the earliest A, like LAT, but for the earliest A during V pacing. Okay, it can be helpful as well.
Okay, very good. The Minglong, if you have something to share your experience with the audience, could you please comment about that?
So actually, this is Ebstein anomaly with multiple SVT. One is the extra pathway AVRT, the other is atypical AVRT, and the third one is the focal atrial tachycardia. So I'm not so sure that the third one is the focal atrial tachycardia, because you haven't done enough differentiation and stimulation maneuvers to differentiate it's a focal atrial tachycardia or it's the septal extra pathway mediated SVT, because the Ebstein anomaly often, like Dr. Park has mentioned, that often the patient can have multiple extra pathway. Often one is on at the free wall, the other is at the septal area. So this is very often. So in this particular case, so one axial pathway is in the inferior wall or posterior wall, posterior lateral. So that's the axial pathway location. And then is the atypical AVNRT, but after slow pathway modification, you have the third one. The third one, the earliest activation is in the the coronary sinus ostium area, but that's often is the the actual pathway location of Ebstein anomaly. So how do you how can you make sure that this is not the actual pathway mediated SVT, but you say that it's focal atrial tachycardia from the floor of the Cook's triangle. So can you show us how to, or you can tell us how to make the differentiation of this focal atrial tachycardia or the AVNRT, Dr. Dony?
Okay. So we suspect this was his AT because first this already we ablate the slow pathway and then the APHRS pathway, and then the VA conduction is already, the retrograde is already blocked before this tachycardia. So there's no more retrograde conduction. So we cannot perform the pacing maneuver from the RV. So, but what can we do? What can we do is we can do the atrial pacing actually. The atrial pacing to differentiate between this more like of AVRT or AT. We can see if it's the AT, there's no AV linking in this particular case. So that's the one that we can do. But in this case, we suspected this is more low of like focal AT because of the loss of VA conduction during the before tachycardia.
No
so retrograde
this
conduction.
Is yes. Just go ahead.
Yeah, thank you very much, Hermanto. Even though there are a few more questions, I'm very sorry I cannot introduce all the questions to the audience because of time limitation. It is already 5 minutes after the planned finishing time. So I enjoyed all three cases very much, and I appreciate all the participants and the presenters, especially to Professor Pathak, Professor Li, and Dr. Hermanto. And also, I would like to great thanks to the Professor Minglong Chen and the Professor Narayan. So I would like to continue this Young AP. The webinar will be more prosperous and informative sessions. Everybody have a nice weekend, and I hope to see you all in another sessions. Thank you very much.
Thank you very much.
Thank you.
Thank you, Dr. Park. Thank you all the chairpersons and speakers. Thank you very much for a great session.
Bye-bye.
Bye-bye.
Bye-bye. Thank you.